Today, we're going to dive into one of the most incredible structures in the entire human body, the knee. I mean, it's a true marvel of engineering that lets us do amazing things, but it's also, incredibly vulnerable to getting hurt. So let's find out why.
So let me ask you a question. We usually think bigger means stronger, right? But what if I told you that the body's largest joint was also its most vulnerable? Well, as you've probably guessed by now, that's exactly the case with the knee.
And this right here is the fundamental paradox of the knee. Yeah, the tibiofemoral joint is the biggest in your body, but its stability doesn't come from a nice, secure, bony fit like a ball and socket joint. Nope, it's basically one long bone just sitting on top of another. The only things holding it all together are the ligaments and muscles. This design is what gives it amazing mobility, but it's also the very source of its fragility. Okay, so when something goes wrong with this marvelously unstable joint, how in the world do we figure it out? Well, the whole process is a lot like being a detective. And the very first step is to gather clues. And believe me, the most important clues come straight from the patient's story. This question is everything. Understanding how the injury happened is absolutely critical because the mechanism of injury, the way it happened, often points you directly to what got damaged. In the world of diagnostics, the how almost always reveals the what. Now check this out. This is basically a diagnostic cheat sheet. If an athlete plants their foot and their knee snaps backward, that's non-contact hyperextension. We are immediately thinking ACL tear. A football player gets hit on the outside of the knee. That force, we call it a valgus force, points right to the MCL. A fall right onto a bent knee, like a dashboard injury in a car crash, we're looking at the PCL. And that classic painful twisting motion while your foot is planted, that just screams meniscus tear. The story practically writes the diagnosis for you. All right, so after we've listened to the story, the next step in our detective work is simple observation. What can we learn just by looking at how a person stands and moves? Turns out, a surprising amount. One of the key things we look for is something called genu valgum. Now, you've definitely seen this before. It's just the clinical kind of fancy term for knock knees. And this specific alignment can tell us a whole lot about the long-term forces that have been acting on that joint. So here's why this matters so much. It's all about where the stress is going. With genu valgum, or knock knees, your knees touch but your ankles are apart. This puts way more stress on the outside part of the knee. The exact opposite is genu varum, or bow legs, where the ankles touch and the knees are apart. That puts most of the load on the inside part. Over years and years, these patterns can lead to really specific types of arthritis and other problems. So we've talked about just standing there, but what about the incredible forces that go through your knee when you're actually moving? I mean, seriously, how much of a load do you think your kneecap, your patella, actually handles? The numbers are going to blow your mind. Just look at this. When you're walking, it's about a third of your body weight going through the kneecap. Not too bad, but climbing stairs, that jumps up to 2.5 times your body weight. And then look at squatting. A deep squat can put a staggering 7 times your body weight through that little bone. It's incredible. This is exactly why the health of your kneecap is so important. Okay, so we've listened to the story, we've looked at the alignment. Now it's time for phase 3. The hands-on examination. This is where a clinician actually gets in there and physically interacts with the knee to feel what's going on with stability, movement, and strength. And there's a real system to this. First up is active movements. That's when the patient moves their own knee. It tells us what they're willing to do, how far they can go, and where the pain starts. Second, we have passive movements. Now the examiner moves the knee for them. This reveals the true range of motion and gives us clues about the joint itself. And finally, resisted movements. The patient pushes against the examiner's hand, which lets us isolate and test the strength of the muscles. Now, during that passive movement part, clinicians are feeling for something really specific and subtle called end feel. It's the quality of resistance you feel at the very end of the movement. For a healthy knee, when you straighten it, you get a firm tissue stretch feel. When you bend it all the way, the calf hitting the hamstring feels soft. But if there's arthritis, it might feel hard, like bone hitting bone. It's this kind of subtle feedback that is just incredibly valuable. So the knee's been examined on the table. It might seem stable. The range of motion is pretty good. Strength is okay. But you know what? That's not enough. Now we get to the most important part, testing the knee under real-world dynamic conditions. This is it. This is the one question that every single patient wants answered.
From the weekend warrior to the pro athlete, they all want to know, can I trust my knee? Is it going to hold up when I need it most? And the exam table just can't give you the full answer to that. But functional tests can. And let me introduce you to one of the most elegant and powerful tests out there, the single leg hop. It's so simple. You stand on one leg, you hop forward as far as you possibly can, and here's the kicker. You have to land on that same leg and stick it without losing your balance. Then you do the other side. It's a fantastic test of power, stability, and confidence, all rolled into one quick movement.
So here's the money shot, the number that tells us so much. We compare the distance you hopped on the injured leg to the uninjured leg. If that difference is more than 15%, that is a major, major red flag. It tells us that even if the knee felt okay on the table, there's a big functional problem. Your brain just doesn't trust that leg to do its job.
Ultimately, functional tests like the hop test help us classify people into two main groups. We call them copers and non-copers. Copers are people who, even with something like a torn ACL, can still function at a high level. Their bodies have figured it out. Non-copers, on the other hand, just can't manage. They have major instability. And knowing which group someone falls into is absolutely critical for deciding what to do next.
And that brings us to our final question, really. We've seen that figuring out a knee injury is a puzzle. It's part story, part alignment, part hands-on tests, part performance. But what truly separates a knee that makes a full comeback from one that doesn't? It's clearly about so much more than just whether a ligament is torn or not. It really makes you wonder what the most important piece of that puzzle really is. Definitely something to think about.